Welcome, everyone. We're so pleased that you could join us today. I am Mark Zuckerman, president of the Century Foundation, and I want to thank our hosts, NYU Wagner, our remarkable panel of experts that you'll hear from in a moment, and of course, our moderator, the Director of Healthcare Reform and Senior Fellow at the Century Foundation, Dr. Jamila Taylor. CF, we are a progressive, independent think tank that drives policy change to make people's lives better. We pursue economic, racial, and gender equity in education, healthcare, and work. In recent years, our experts have been on the forefront of efforts to defend the Affordable Care Act. And now our work focuses on ways to expand affordable coverage to all Americans and close healthcare gaps facing low-income communities and people of color. We're very excited to welcome you to today's panel where we will discuss policy ideas to make strides towards eliminating health disparities. With that, I'd like to introduce Sherry Gleed, my friend and Dean of NYU Wagner Graduate School of Public Service, who herself is a leading expert in the field of healthcare. Sherry, over to you, and great to be sponsoring this with you today.
Likewise, thank you, Mark. I'm Sherry Gleed, Dean of NYU Wagner's Graduate School of Public Service. Today's discussion is going to focus on a topic that I think has really been in the news, the tragic, long-standing, and preventable health disparities that we see all around us and that have been brought to the forefront by COVID-19. We know that marginalized groups have been disproportionately impacted by chronic disease and premature death, and now I think there is an ever greater consensus among Americans that health inequity is an issue that needs to be addressed. That's the genesis of this panel. I want to welcome our moderator, Dr. Jamila Taylor, who's Director of Healthcare Reform and Senior Fellow at the Century Foundation. She herself has had a very impressive career championing the health and rights of women, both in the US and around the world, at the Center for American Progress and at IPAS before coming to the Century Foundation. And when we started this discussion about having this event, I immediately thought of two people who would be fabulous to talk about it, and I'm so delighted that they were both willing and able to join us. They're both experts and I think friends at this point. Amitav Chandra, whom I've known for a very long time, who's the Ethel Zimmerman, I shouldn't say that because it makes us both seem old, no. Ethel Zimmerman Weiner Professor of Public Policy at the Harvard Kennedy School, and also Professor of Business Administration at the Harvard Business School. And Dr. Abdul El-Sayed, whom I've only known since May, but in a very intense way, who's a physician and epidemiologist, former city health commissioner, and a progressive activist. So thank you both very much for joining us. Thank you, Jamila, for moderating. During the event, you can submit your questions by clicking the Q&A button on the screen. And now I welcome Dr. Taylor.
Thank you, Sherry, and good afternoon to all of our folks that have joined us today. As Sherry mentioned, I'm Dr. Jamila Taylor, Director of Healthcare Reform and a Senior Fellow with the Century Foundation. So I have the pleasure of moderating today's event. And as Sherry mentioned, we have Dr. Amitav Chandra with us, as well as Dr. Abdul El-Sayed. And if you want to see more in terms of their extensive bios, feel free to go to tcf.org to take a look. So let's jump right in. The first question goes to both of you. Why are some of the main things that we see in healthcare disparities for marginalized groups, particularly across racial, ethnic, gender, class, and age lines, manifesting in terms of both access to healthcare services as well as health outcomes? And why don't we start with Dr. Chandra first?
So thank you, first of all, to everyone at Wagner and the Century Foundation for bringing us together. So first of all, I'm an economist, so I think we should really be listening to Dr. Abdul El-Sayed in his capacity as a doctor and as the former city health commissioner. But the way I think about it, I think about racial and ethnic differences in access to doctors, in access to preventive care like vaccines, in access to high quality hospitals and nursing homes. But I think there's more to healthcare disparities than just healthcare. I think that there are disparities in health insurance that amplify these disparities. Just if you look at a map of the states that have decided not to expand Medicaid, what are their names? They're called Mississippi, Arkansas, Tennessee, Georgia, South Carolina, North Carolina. states with disproportionately large African American and minority communities. So you can see how this decision not to expand something as simple as Medicaid has a disproportionate burden on racial and ethnic groups that is bigger than, I think, that compounds the disparities that these groups already face when they have health insurance. And I think the last comment I'll make on this broad question is, I think we don't think enough about disparities that originate from basic science itself. So even before we get to sort of, the biases of doctors, I think we have to sort of ask ourselves, what are the biases, and we've talked about the biases of policymakers, but what are the biases of just life scientists? We often think of them as not being biased, but look, we know that the prevalence of triple negative breast cancer is twice as high in African American women than it is in women of European ancestry. But the R&D on triple negative breast cancer is a lot less. I'm not saying that's all because of race. The science is hard too, but the science can be solved. So I think when we think about these racial and ethnic disparities in health and healthcare, I think we want to paint accurately, but paint a fairly broad canvas of all the factors that create these.
Right. Thank you, Dr. Chandra. I love how you brought in, the fact that we have to look at the structural issues that implicate health disparities, as well as, even how our research is done, and how there could be some biases there as well. Dr. El Said, how would you respond to this question?
Yeah, I just want to, again, say thank you to NYU Wagner and my good friend Dean Gleed, as well as the Century Foundation for creating this opportunity to have a really important conversation in a moment like this. And really appreciate you, Dr. Taylor, for convening us and moderating the discussion. And it's great to meet Dr. Chandra. I've read a lot of your work, but never got to meet face to face, although this is not really quite face to face either, but this is as face to face as we get in the middle of a pandemic. I actually want to even step a bit further back because there's an important difference here between health and healthcare. And my argument is actually to say that in origin, right, most people don't actually want healthcare. They want healthcare because if and when they lose their health, healthcare is a means to get back to health. And the point I often make to folks is that, if you're perfectly healthy, and I offer you, the amazing deal of 5 MRIs of whatever part of your body you want, for $500, right? You can't sell them; you just have to have them, right? It's a MRI for free card that you buy, 5 for $500. Nobody would buy it. The problem is that if you were to, be playing basketball and sprain your ACL or tear your ACL, and I offered you the same deal, you would definitely buy it. But here's the catch: I would then offer it to you for $5,000. And you might say, that's still probably a good deal because in the end, my hospital/insurer, if I have an insurer, right, the deal comes to something different. And the point that I'm trying to make here is that health is what we want. Healthcare is not. And if we want to understand health disparities, we got to start with where the space is that takes away systematically the health of people of color. And to understand that, it has a lot more to do with what happens outside of the clinic or hospital, the air that people breathe, the places that people live, the access to education that they have, the jobs that they work. And I think a perfect example of this is what happened in the moment of COVID-19, right? We have a healthcare system. COVID-19 is a particular hazard into that healthcare system. And look at what happened, right? Yes, people lost insurance because they lost jobs. Yes, our hospitals got overflowed because of COVID-19 patients. But really, a lot more of it had to do with the fact that if you are a person of color, you're less likely to have higher education. You're less likely to be able to work behind a camera like this. You're more likely to have lived in a community where you had to breathe air that was systematically polluted by some polluter, which led to a baseline degradation in your lung function, which then in the context of COVID-19, which you were more likely to be exposed to because you still had to choose between going to work to save your livelihood or staying home to save your life and the life of the people around you, that in that moment, right, you were less likely to have access to a good hospital, less likely to be insured, and more likely to die. In fact, 3 times as likely to die if you were Black. in the early days of the pandemic. And so it is this interaction, right, of all of the means by which our society has systematically marginalized groups of people that reduces their baseline health in the first place. And then the fact that our healthcare system, because it carries the same systemic biases as all of the basic systems that folks rely on to live a dignified life, right, it fails to rescue people of color from those consequences. And so I would encourage us, when we think about health disparities, not only to think about healthcare disparities, the differences in care and access to care that people have, but the differences in the baseline probability of getting sick in the first place. That's a function of all of the ways in which systematic oppression, lack of access to basic resources shapes a life and makes it less healthy.
Thank you so much. And, you know, the fact that you bring up systemic oppression is key in this conversation. You know, we didn't get to this place out of nowhere. There's a long history in this country that we have to reckon with when it comes to marginalization, subjugation, particularly of Black and brown folks in this country. If we look at experimentation on Black and brown bodies, which is something that has been well documented over a number of years. And it has also led to a distrust in the health establishment of people of color. Can you talk a little bit about how racism shows up in the healthcare system? I think we love to talk about bias, right? Because that's sort of the low-hanging fruit, you know, in these conversations. Bias almost feels like something that we can address more easily. It's more about subconscious views and stereotypes of people that are different from you. But talk a little bit about how racism shows up in healthcare. And this could go to, why don't we start with Dr. El Said first, and then we'll go to Dr. Chandra.
Sure. So, you know, the thing about racism, and I want folks to really appreciate this, is that the part of racism that we often see is actually not even the part that is the most dangerous. It's kind of like an iceberg, right? You see the tip of the iceberg, but it's not the tip of the iceberg that kills you. In fact, if you can see the tip of the iceberg, you can skirt the iceberg when you're navigating. It's the part under the water that is so deadly, right? You think about what sank the Titanic. It was an iceberg that they could not see under the water. And so what we see of racism tends to be these inter-individual racist in interactions, but those aren't even the deadliest part. The deadliest part is the way that racism starts to shape the beings and doings of a particular institution, the structures underneath those institutions in the first place. And so, yeah, systemic bias, racism shows up in the ways that physicians and nurses and hospital employees may treat patients of color differently. But it also shows up in the fact that Black folks are less likely to be those doctors in the first place, right? Because of all of the differences in access to a high quality education in a neighborhood that offered that. And to take that all the way back, right? When we think about racism and anti-racism, it's not enough just to address the tip of the iceberg and end racist behaviors. You've also got to go in and uproot the racism that existed that holds people back in the first place. And that tends to be institutional and structural work. So let's just get at that question of disparities in access to a medical education, right? We wrote a paper back in 2013 looking at differences in medical educational debt. And we found that Black and brown folks had higher debt systematically. And that's if they got to med school, right? Now think about the educational system, just the K through 12 educational system that's a feeder into college. We pay for education via property taxes. Property taxes are a function of the value of land. And the value of land is a function of how much investment has been put into that land. And we know that differences between Black and brown neighborhoods versus white neighborhoods as a function of racial residential segregation, which, by the way, was federal policy all the way back from the Federal Housing Administration. We pattern, right, that systematic investment and subsidization of white homeownership in white communities, right, versus the lack of that subsidization in Black homeownership in Black communities as a function of the Federal Housing Administration, as we continue to allow basic K through 12 education to get funded by property taxes, which are a function of that subsidy. And so, you know, that patterns then the kind of education a kid gets as a function of decisions that were made by the federal government way back in the 1940s. And when we think about the system as it is, we tend to cut the history out of it, right? As if the system is just what it is. But we've really got to be thoughtful about going all the way back into history and asking, how did race pattern access to these things that then feed all the way down into who gets to go to a good college, who gets to go to med school, and who's got money to pay for med school, that then feeds into who the doctors are that take care of patients. And all of this is about the way that racism is bigger than just the individual interactions between a patient and a physician. It has everything to do with the hospitals and who is employed there in the first place. We could also talk about, where hospitals are, which hospitals get funded, who got to go to the hospitals in the first place, and all of this follows those same sort of geographic, spatial, racial patterns. And we've got to be really serious about those structures if we're serious about uprooting the impact of racism in healthcare.
No, you're absolutely right. Now, just add to that to say we also like to blame people of color for being sick, for living in neighborhoods that may have high violence or living close to environmental toxins. So that's also a piece. I think I love how you drew out all of those ways that we see racism manifest in the system and how we've seen that through history, but then also the personal blame is a piece of it too. Dr. Chandra, would you have anything to add to this question?
Yeah, a couple of things. One is just to your point about trust. We know that for 40 years, the Tuskegee study of untreated syphilis passively monitored hundreds of adult Black men for syphilis, despite the availability of an effective treatment. And, we all also know now that the methods of this study have become synonymous with exploitation and mistreatment by the medical profession. Here's the but. The but is that when we disclosed this study in 1972, there was an increase in medical mistrust by the African American community of the healthcare community because of the study that had been done 40 years ago. And I struggle with that a lot because this was a terrible study and we were right to disclose it. But my colleague Marcy Alsan, who's an infectious disease doctor and an economist, says that, life expectancy for African American men fell by about a year and a half in response to the disclosure of the study. This is pretty big. This is about 30%, the size of the life expectancy gap between Black and white men. So these studies and even their disclosure shock people to the point that they start to distrust the healthcare system. And I think we have to do better than say, let's change everything, because that still is insufficient for how do you bring trust back into the healthcare system. I think we have to be more precise about how you bring the trust back, and saying we want to dislodge everything might not bring the trust back at all. So I think we have to be more precise in terms of what we want to do on the policy side. I very much agree with Dr. El-Said on the importance of African-American physicians. The same physician, Marcy Alsan, did this wonderful RCT where she randomly assigned African-American men to Black and non-Black male doctors. And this was really interesting because a lot of this research to date has focused on the fact that African Americans make up 13% of the population, but they're like 4% of the physician workforce. And we all agree we've got to improve on that. But I think for someone like me, one question I want to know the answer to is how much better would African American health outcomes become? And she finds that the African American men who were seen by African-American physicians, so where there was race concordance, actually were agreed to much more preventive care than African-Americans who were seen by non-Black doctors. And a lot of the answer in her work, and I think this is kind of borne out by a lot of work done in ethnography or by ethnographers, is driven by better communication and trust. So, my own sense increasingly is as we start to live in an era where more and more of chronic disease can be managed medically, trust between the doctor and the nurse, between the patient and the nurse, the patient and the doctor, matters more today in 2020 than it did in, say, 1920, when we didn't have this big armamentarium of drugs called statins or PCSK9s or treatments for hepatitis C. So I think that the issue of trust, and therefore this issue of, you know, how many African American physicians do we have, is more important now than it was 100 years ago.
No, you're absolutely right. And in this conversation about trust, you know, it brings up the issue around, you know, the COVID-19 vaccine. You know, it's been reported recently that, you know, most African Americans are actually hesitant about the vaccine. And so are you all, you know, concerned about that? And what can we do to help make sure that they have the information that they need about the efficacy and the safety of this vaccine, especially as they're one of the communities, you know, most heavily impacted by COVID-19? And why don't we start with Dr. Chandra and then go to Dr. El-Sayed?
And look, I am very worried about this. We know from the epidemiology literature that minorities are actually more distrustful of vaccines. And as a result, are actually more likely to adopt behaviors related to hygiene, like social distancing, increased hand washing, maybe even calling up a healthcare provider. These are all substitutes for actually taking the vaccine. If you look at influenza vaccination rates between Blacks and whites, what's interesting is that there isn't a disparity. There isn't a racial disparity in flu vaccination rates if you're on Medicaid or if you're on Medicare. So in the public health insurance programs, there isn't a disparity. It's low, it's about 40% for both groups, but it's not like it's, you know, it's 40% for whites and it's 30% for Blacks. In private health insurance, this is actually commercial health insurance, which is usually viewed as, you know, kind of better, more generous. That's where you see a big 10, 15 percentage point difference in vaccination rates, right? Which is really interesting because the African Americans who are covered by commercial, by private health insurance, are richer or higher income. So I think we have to understand that better and sort of also understand that the public health insurance program actually has figured out something. The doctors who work in it have figured something out that we should understand. Dr.
El-Sayed, any response to this one?
Yeah, I am concerned about hesitancy with this particular vaccine for a number of reasons. One is all of the historical racism and the long shadow of a history of the biomedical establishment taking advantage and exploiting Black folks and Black bodies. Another, right, is just this is a unique moment of misinformation in our country, and I don't think we have quite come to appreciate the structural consequences of you know the change in the way that we communicate on public trust and public engagement and belief in institutions. I also think, though, that there is a, you know, when we think about this, oftentimes there is a actor-specific or agent-specific or individual-specific approach to thinking about health behaviors that I think, Dr. Taylor, you alluded to, that sort of speaks to an implicit victim blaming, right? Because, you know, if I grew up hearing the stories about you know, what they do to people like us in those hospitals, and then I choose not to trust them, I'm just being rational at this point, right? And you know, whether it's a vaccine or it's, you know, the advice to eat healthy or exercise more, I think we've got to be a lot more thoughtful about what we do on, you know, and I'm speaking as a former health commissioner, what we do to center the experiences of people that we are trying to serve, rather than to assume that if they don't center their lives around our bureaucracies and our systems, then they're acting irrationally. And, you know, the vaccine is one thing. This is sort of a shotgun moment, right? We've never really had to deploy, you know, research and develop and then deploy a vaccine in 18 months, right? That's never happened before. And we're learning in a lot of ways on the fly. But like, even just step back and talk about, you know, the still #1 and reigning killer of all people, including Black Americans, heart disease, right? When we talk about the sort of health behavior risk factor paradigm, what we fail to recognize is that, you know, if you want somebody to exercise, probably the most important thing you do is offer them easy access to exercise opportunities. But, you know, I was the health commissioner in the city of Detroit. We decimated our public transit system because, of course, GM, Ford, and Chrysler wanted to demonstrate how the car was going to revolutionize American life. We don't have the density to be able to sustain a circumstance where you can just walk to where you need to go in a city like Detroit. And the reality is that our auto insurance is so expensive that people don't even have cars. And so if I'm somebody who's working 2 and 3 jobs, I'm trying to navigate the transit system, and I get home and the sun goes down by 5:30, and you tell me, yeah, you should just go walk outside, right? And I live in a neighborhood where I'm liable to be victimized for doing that. I'm not doing that. That's just it, right? And if you tell me, you should eat healthy, and there are 23 McDonald's restaurants and 22 grocery stores in my 138 square foot city, right? I'm probably not doing that either, because it's really hard to get my hands on that food, right? A Big Mac meal is the same cost as 2 bags of spinach. And a Big Mac meal is a meal, right? 2 bags of spinach is 2 bags of spinach. And so we've got to be real thoughtful about how it is that, in the absence of appreciating the structural limitations on the ability, right, to achieve the quote unquote behaviors that we want, the way in which our recommendations to eat right and exercise, in effect, blame the people, right, for failing to do that because they don't have the structural circumstances that facilitate it, right? And there's this sort of philosophical idea called the hermeneutical fallacy, where I assume that the things that I do, right, have the same meaning to me as they do to other people, right? And or I assume that the circumstances within which people are operating are the same for me as they are for other people. And the problem is that the people making these recommendations tend to be people like us, right? For whom, like, the reality is that the choice of eating right or exercising is a choice, because the structural realities of our life don't dictate whether or not we can do those things. And so, I just want us always to be centering, right, the difference in a lived experience in a vastly unequal America when it comes to the antecedents of health in the first place, and then the access to healthcare from there, and the humility that we require to be able to put ourselves in someone else's shoes and ask, all right, what do we need to solve in order to empower you to do a thing that seems imminently easy for somebody of the privileges that that all of us, by dint of being on this meeting, have.
Thank you so much. And I could talk to you all day. You're my people. That's for sure. And, but I should definitely shift to audience Q&A, because a lot of questions are coming in. So the first question I will start with from the audience is, healthcare disparity is not just racial and socioeconomic. It is also a geographic problem. And, Dr. El-Sayed, you talked about this in particular. In most states, including New York, there are regions with limited providers and facilities. How do we get healthcare to people living in provider shortage areas? And why don't we start with Dr. El-Sayed, and then Dr. Chandra, if you have something to add.
Yeah, well, the reason I believe that fundamental health insurance reform is necessary, and I am such a proponent of single-payer healthcare, is because it finally says that the value of everybody's body is the same, and that it incentivizes providers to locate into communities that have tended to be forgotten simply as a function of the fact that the reimbursement rates for caring for those people are not the same, right? And so the problem that we have right now is that we have such a tiered system that if you go into any lower income community, be it an urban community or a rural community, right, the return on investment in opening up a clinic in that community tends to be low, because the reimbursements are low, because we basically said that the value of people's bodies, if they are on Medicaid, is lower, right, for caring for them than if they are on private insurance. And so because of that tiered system, we end up having a hollowed out access to health care, not just insurance, right? Let's be clear, if you're on Medicaid in America, you are underinsured as a function of the program itself. And because the program does not reimburse to the point where you can attract the kind of healthcare resources into those communities, you end up being underinsured and accessed when it comes to access to healthcare. And so I do think that a solve here, right, is going to be to say, well, we are going to reimburse care for lower income people, whether they be urban or rural, right, in the same way that we reimburse care to upper income people and even middle income people. And so I believe that we've got to be thinking about the system's impact of some of this. I also think there are some, a couple of easier solves, right? Thinking about the role of telehealth, thinking about, the way that we pay for hospitals, in terms of global budgeting. I think those things are important and valuable, but really, unless we address the fundamental issue with respect to the incentives that exist in the system that we have, we're going to continue to have the kind of health access disparities that the questioner asked about.
Absolutely. Dr. Chandra?
Yeah, so, two thoughts listening to Dr. El Sayed. One is, I am just substantially less convinced of the argument that leveling the reimbursement playing field will lessen, even a little bit, racial disparities in care. I don't see any evidence for that. Medicare has the same sort of, it's the public system, regulated rates. Virtually every paper on racial disparities in America uses Medicare data. We see the same disparities in Medicare that we do in Medicaid, so it's not just a federal government, state government thing. We see similar racial disparities in Canada and in the NHS and in single payer systems. I think disparities in healthcare originate, as we started, with much deeper drivers around racism and bias than they do around something like reimbursement. I'm not opposed to the reimbursement hammer being used if we had evidence that it would work. So in Medicare, where we know the most about racial disparities, the payment systems are the same. A hospital in Memphis is paid the same as a hospital in the DRG payments are the same. The disparities, though, are enormous for all the reasons that you laid out. Now, one disparity that we don't talk a lot about is not just disparity in accessing a hospital, but disparities conditional on access. So the quality of hospitals in some geographic markets in Medicare varies a lot. So hospitals in minority serving regions of the United States have lower quality as measured by validated risk-adjusted mortality than hospitals that serve, majority populations. This contributes to racial disparities in health outcomes. The good news is that those disparities have been shrinking. So the gap in quality disparities between, say, the hospital market in Memphis and the hospital market in Nashville have shrunk a lot in the past 20 years. They've almost completely gone away. But what remains is the fact that if you compare a white patient and a black patient who now live in the same zip code, so they don't live in different hospital markets, they live in the same zip code, African-American patients still, conditional living in the same zip code as another white patient, go to a lower quality hospital in Medicare. So it's not about networks and private health insurance, in Medicare, because of the long reach of history. So if I was always going to some hospital, back in the 1940s and 50s, when my parents went there, I continue to go there, and that hospital tends not to have, better health outcomes. We have to engage as advocates very seriously with this fact, because this is not a fact that's going to be solved by leveling the reimbursement playing field. It is a fact that will be solved by changing the hospitals that minority patients are going to. For whatever reason, they might not know any better. Maybe they know better, but they don't like the patient experience at the hospital with the better clinical quality. Those, I think, are the policy opportunities that we should be seriously engaging with.
Mm-hmm. If I can just quickly respond to that point. Yeah. So I appreciate the points that Dr. Chandra is making. I will say though, right, that point that you made about preference, I'd appreciate unpacking that a little bit, right? Because what tends to happen over time is that you end up getting a really segregated medical experience. And the differences between high quality hospitals versus not high quality hospitals tends to be a function, right, of how much money gets moved into those hospitals. So I was a medical student at Columbia University. And when I was a medical student, I did some of my rotations at New York Presbyterian Hospital, right, one of the highest income, best rated hospitals in the world, and Harlem Hospital, which is decidedly not. And you think about who you take care of in both of those hospital situations and why it is that those hospitals tend to be differently resourced. And it has a lot to do with the patient mix and the reimbursement rates for those mixes. Now, look, your point, right, caveated on, and this is how I started my entire argument. Healthcare is a very small part of health, right? And so you're not going to solve the problem of health outcomes by doing anything in the healthcare system. I've given up on that idea, right? I think you're going to solve the problem of health disparities by doing something in society, right? Poverty, differences in access to housing and air and water and all of these resources that shape a life. But if you want the healthcare system to be a part of the process of improvement, then you do need to even out the balance, right, of how much money patients implicitly will bring with them. Because right now, right, the sort of unsaid piece of your argument is that some hospitals are just good and some hospitals are just not, right? But the reason some hospitals are good and some hospitals are not is a function of how much money their patient set brings to those hospitals and allows them to be invested in being good or not good hospitals. And so, you know, we can't sort of blame the circular logic of, you know, sicker patients go to worse hospitals and therefore remain sicker, right? The question we have to ask is, but why, right? Well, that has everything to do with reimbursement rates that those patients bring with them. And I would bet that even in the same zip code, right, you will find that the proportion of patients who end up going to the high quality hospitals tend to bring with them better reimbursement rates versus the patients who go to the lower quality hospitals.
Except, Dr. El Sayed, I was looking at Medicare patients. So I'm looking at where Medicare patients go.
No.
So but they're bringing the same reimbursement with them, right?
But I agree with you, but it's not, you can't just disentangle the patients from the patient mix the hospitals get. So if you're just looking at Medicare patients who go to different hospitals, you're right. But ask yourself where that patient went before they had Medicare, right? The higher probability is, yes, once you age to 65, you get Medicare. But if you are a lower income Black patient, you are probably more likely to have Medicaid your whole life. So you grew up being shunted into the lower quality hospital because that's the place you went. But and then you get Medicare, right? And now you can go to any hospital you want, but you don't know that.
In our analysis, the hospitals that get a lot of Medicaid are actually very good hospitals, are very, very good hospitals. So I think this thinking that, well, this hospital gets a lot of commercial money and so is very rich and therefore very good is not true. And I think the minority serving hospitals are very, very good hospitals when they get, here's where I agree with you. And here's where I disagree with you. As long as the state government doesn't take away dish dollars from a hospital that gets dish dollars because of fiscal shenanigans, money matters in healthcare. So if you give a hospital more money, it improves outcomes. Very often, what states do is they say, Dr. El Sayed's hospital got this dish payment, so I, the state, I'm going to like sort of take money away from the state. But this goes back to, again, sort of the public sector coming along with kind of very ad hoc ways of, you know, kind of moving the money around, which isn't good. So to your other point about why are some hospitals good, a lot of the story is actually hospital leadership. Hospital leadership matters. You know, it's an input like everything else. It's not just the cath lab. It's not just the cardiac surgeon who works there. It's not just the money. It's literally the quality of the CEO and the boards that run these hospitals. I think leadership, professionalism, management matter in making some hospitals good. Other hospitals don't have that. And I think that's something that we should study and explore because it's a policy solution that acts a lot faster than some of the other policy solutions we've been discussing around diet, around exercise, you know, around changing the number of minority physicians. Those are important to do, but we're basically telling people for the next 30 to 40 years, you know, hey, we don't have an answer for you because we decided to stop working on healthcare.
No,
we should continue to work on healthcare.
I don't disagree that healthcare is a really important thing. I also, that's entirely why I believe that we ought to very much reform the healthcare system. I just think the small ball reforms aren't that valuable. The only other thing I'll say is that, you know, money attracts great leadership, right? And so it's a bit circular. I mean, there's a reason that you teach at Harvard, right? I could invite you to go teach at, you know, some other school that doesn't have the same money and resources, right? You teach at Harvard, right, as one of the best and brightest in your field because Harvard is Harvard and Harvard has resources, right? And so all I'm saying is that it's a little bit circular to say, well, it's just these human factors and leadership. And you're like, well, where does good leadership go? Good leadership tends to go to places that are prestigious and have money, right? And so there is a So long as there is a form of stratification in our society that emerges at the patient level, that stratification is going to follow up. It's going to move up in the system, and it's going to show itself in terms of hospital leadership and the kind of doctors that get employed, et cetera, et cetera. And so,
yeah, but Dr. El-Sayed, I think the question is, I don't think the public sector is immune to those forces, right? So if you look at the NHS in the UK, right, like sort of the role model system, and why are the London hospitals then better than the hospitals in Swansea, Wales? Or why are the London hospitals better than the Aberdeen hospitals in Scotland?
Resources.
It's because we figure out, even in the public sector, how to give the hospitals where the rich and the famous go more money. We might not call it reimbursement. We might call it like a special fund to do science or research. So I think I agree with you that money matters in healthcare. I just don't think the public sector is immune to these forces.
But it's a lot better, right? Because in the UK, health disparities are a lot less flagrant.
I don't think
than
racial
they are in the US.
disparities, I think there's a lot of work done on this. Racial disparities.
I wrote my thesis on health disparities in the UK, and they're not as bad as they are.
Not racial disparities. Racial disparities are just as big in the UK as they are in the
US. They're not spread as deep. They exist, no doubt, right? Racism exists, don't get me wrong. But they are not as deep or profound in the UK as they are in the US. Not even close.
Okay, well, this is exciting, such an exciting back and forth. And, you know, like I said, we could go all day. One thing I would add to this, you know, debate that you all are having too is patient experiences, right? And so we also have to factor that in terms of, you know, where a hospital is, what neighborhood it's in, whether we call it quality or not. I think if you have a number of patients of color that are going there and they're not getting good, encouraging experiences with those physicians, then then they are going to decide to go to, you know, another hospital that may not have those quality standards meeting them in the textbook way, but they may have people that they identify with there. They may be feeling, you know, more warm in interactions with the workers there. So I think that's also a piece of this that we have to keep in mind. And so we have time for one more question. You know, from the audience. And again, we have a lot of questions here. And so apologies in advance to folks that are participating today that we can't get to everything. But I wanted to end on this one. What is one policy that you'd like to see passed by a Biden administration to challenge healthcare disparities? And let's start with Dr. El-Sayed.
Well, I'm really heartened. I'm excited about the whole team that the Biden administration is naming. I'm really heartened, though, that he's announced Dr. Marcella Nunez-Smith to lead a COVID equity task force. I think that if we are serious about health equity, then we have to invest in addressing health inequities at the very top of government and at the very grassroots. And so being able to identify the problem and to identify leaders who are going to be responsible for the problem, I think is really quite critical. And so I'm really heartened by that and really excited to see what they do.
Dr. Chandra?
So I agree. I think that he's off to a flying start. I mean, it's just really incredible that given all the troubles he's had in putting this team together because of COVID and because of an intransigent incumbent, you know, he's gotten to where he has, which is absolutely fantastic. I would ask for, you know, two things. One is, I think we don't spend enough time researching diseases that disproportionately affect minorities, right? So if you think about sickle cell, if you think about beta thalassemia, you know, we are starting to see some drugs that could be fantastic, maybe even curative, but there are many other diseases that are disproportionately the domain of minority patients. And I think we need the NIH and the basic science side of the aisle to think harder about disparities in basic science research. Are we just studying the diseases that, you know, majority people are likely to have? They're likely to have Alzheimer's. Minority patients are not likely to live to the point of getting Alzheimer's, right? So we need to think and engage with this a lot more seriously. In the very short run, though, I would like to see us have a difficult conversation around the performance of minority-serving hospitals and whether the policy solution is to give minority-serving hospitals more money, because more money would allow them to buy better inputs, better CEOs, better leaders, or whether the policy solution is to move patients to another hospital, like you just tell the ambulance drivers to go to that other hospital, right? Because that could have overnight effects on their survival. Overnight effects. That doesn't require spending more money, but more importantly, you don't have to do anything. You just have to say, these two patients live in the same zip code. You're taking this patient to this hospital, now start to take them to this other hospital, because it could pay off immediately. Now that has a number of difficult side effects. You know, would the minority serving hospitals start to go out of business? It might. But we don't really care about minority serving hospitals going out of business. I care a lot more about minority outcomes. So if I'm improving outcomes and some hospitals are closing, I care maybe a lot less, as long as outcomes are improving. So I don't think that taking on disparities in the short run is sort of one of these win-win kinds of things. And so I think we're going to have to figure out, you know, what is the best evidence that we can bring to bear to start to reduce racial disparities tomorrow, not 10 years from now, not 5 years from now, but tomorrow, as in, you know, in the fourth week of January.
Absolutely. I definitely agree with you. And it's a good thing that the Biden-Harris administration is already thinking about these things, and they've prioritized addressing health disparities. So thank you all so much to Dr. Chandra, as well as Dr. El Said, as well as all of those who participated in the event today. I'd also like to thank the teams of the NYU Wagner School and the Century Foundation. If you want to learn more about the events coming up, as well as see the bios of our great speakers today, please visit tcf.org, as well as wagner.nyu.edu. Thank you.
Thank you, Dr. Taylor. And a great exchange, Dr. Chandra. Looking forward to the next one.